So we'll be starting with our question and answering session pretty soon here. You can ask any question that you want, and we have a moderator for this session, which is the lovely Susan Jones.
Well, I'm Dr. Susan Jones. I'm the Director of Veterinary Affairs for Hills Canada, and it's my privilege this afternoon to end up our session by helping you to get your questions out that I know. We started to have some lively discussions earlier in the day. It's too late for that. Well, actually, thanks to everybody for all your feeds that you sent during the day, because we have lots of great questions. And my Hills colleagues have been helping to review those and kind of amalgamate some of them together, because there's some really common questions, and we have the panel of experts to help us answer them. First of all, just help me to thank our 9 wonderful speakers from today. I really hope that you enjoyed the program as much as I did. In the morning, we had some great clinical topics. In the afternoon, we also had some very accomplished clinicians that were helping us more with the art of veterinary medicine, because we all really understand and know that unless we hone and continue to improve those skills in the art of veterinary medicine, we don't have the opportunity to apply all the wonderful clinical knowledge that we have. So keep in mind, and I hope you jotted down some of the questions that you had throughout the day. I have some of my Hills friends that are helping me with microphones. Where are you? There's one there, one there. And so we will take questions from the floor. One there, 3 microphones. Thank you, Amy. Because we had such great feeds, I'm going to start us off with a question that was very commonly asked. And it's one I'm not going to direct to any single doctor, so don't fight over the microphone. But it's a really very common question. This morning, we had several speakers. In fact, I would say all of you this morning, in one way or another, encouraged us that the earlier we can diagnose osteoarthritis, the more successful we can be in managing it. But we also know, and our speakers acknowledged, and many of you said, I get that. But I don't usually see the pet for osteoarthritis until the owner brings it in, because they've noticed a lameness. So, doctors and experts from this morning, what tools can I use to help me diagnose osteoarthritis before the pet owner notices the lameness? Dr. Robin Downing.
So, one of the points I made is that we have to learn pain assessment and pain recognition the same way we learned ausculting an abnormal heart, and that means conducting a pain assessment on every patient every time from the time they're little wee babies, so that we not only can recognize abnormal when we feel it with our hands and see it with our eyes, but so we know the difference in an individual animal. Here's the illustration I'll use. How many of you have ever worked with a Labrador Retriever? Anyone? How many of you have ever worked with a Labrador Retriever who just ran through barbed wire and still has the pheasant in its mouth? Okay? You know how they behave. How many of you have ever worked with a Samoyed? How many of you have ever worked with a Samoyed with a broken toenail? Counselor, I rest my case.
Thanks, Dr. Downing. So other speakers, thoughts that you might have about how you want to help our veterinarians?
I always think you start dealing with osteoarthritis at the end of the one pet, but more importantly for the beginning of the next pet. Because I think you can't really educate, and we talked about so much good material today, you can't educate an owner about the importance of nutrition during growth as it relates to osteoarthritis, what to do with clinical signs, and what are the treatment options. There's too many things that can be done. You really want them to learn as early as possible. So screening, for example, I don't want to hear, I have to wait for a dog to be limping for months and months. It's often way too late to save a joint. So you really have to talk to them about what a puppy looks like, if a puppy is slower than other puppies. You've got to discuss screening before that puppy comes. It's too late by the time they are there for their vaccine. It has to be planned earlier so it's better accepted. And they can do their own reading. You can discuss it. Spend some time, at the end of the previous pet or in between pets to talk about osteoarthritis So then you can do something very quickly.
And I'd also just like to add physical exam, just watching animals, watching their gait, looking for abnormalities in the gait, and that has to go along with pain scoring, but knowing what a normal gait looks like, and then also going through range of motion and palpating their joints at their wellness exams. So you may be able to pick up that pain before the owner does.
And I'll say one last thing. Puppies don't do anything funny. And always people are going to come to you, they're going to say, he does this funny thing. I've heard it 1,000 times. And I tell them, puppies don't have any sense of humor whatsoever. They don't do anything funny. Anything they do that is funny is done to relieve pain or to be able to do something that would otherwise not do. The puppy that's stuck from the little swimming pool there when everybody else is gone has a problem, usually. The puppy that falls down every 10 seconds, the puppy that can't move around as well as the other, or sleeps in a funny position. Every one of them has a problem with their limbs. So if you see anything funny, just let me know or let the doctor know, because there is a problem with that puppy.
Okay, thank you very much. And I can't resist a companion question, and then I'll open it to the floor and to you. If we are indeed able to use some of your advice and work harder on diagnosing earlier, using some of the techniques and tools that you've just offered to us, what do we do about it? Because again, so often clinically, we're seeing a situation where the owner has noticed a lameness, a problem. It may be fairly well advanced by then. If we reach that nirvana where we're able to diagnose earlier, before the owner sees it, before really obvious clinical signs are there, what should we do about it? Yes?
Well, I think early treatment, really has to do with weight management, nutritional optimization, and an exercise plan. Those are the three things that I really try and tell people. Again, when you see a puppy before it is overweight, making sure that those owners realize how important body weight is and conditioning, and that you're monitoring that as the dog grows. Because once they're heavy, it's harder for them to lose that. It's easier to prevent that. So making sure that their weight is optimized, that they are consistently exercising their dog in a controlled manner. Long walks and, just consistently active, and then making sure that they're on a good diet. Those are just the three basic things that I try and instill in every person that I talk to that has a dog.
And I think, too, so point number one was we need to follow the science, and I think that we owe it to ourselves, to our clients, and to our patients to pay attention to Ben Hart's data coming out of the University of California at Davis, because he's looking very hard at how can we be more mindful of allowing our patients to optimize their growth in a way that doesn't compromise their skeletal system. And interestingly enough, Ben was just in Denver to present his data in greater depth, and his ongoing publication will be, it will reveal data around other breeds of dogs. His first paper was on golden retrievers because that is what was funded first. But he now has data on Rottweilers, Labrador retrievers, and it turns out, and even toy breeds, so it turns out that we can't make blanket comment, but it behooves us to pay attention to newer data as it becomes available, because it will alter our recommendations if what we really want is to provide our clients with information about what their pets need and deserve.
Thank you very much. And please, hands up if you have a question. Right here, and Heather is on her way with the microphone. Yeah.
We had a great discussion today about osteoarthritis in dogs, and I just want to mention that Hills hasn't talked about JD in cats, and I personally use it in a lot of cats for osteoarthritis. So I'd love to see more discussion about nutrition in cats and arthritis, since it is one of the few things we actually can do for cats with arthritis. So just a comment more than a question, I guess.
Okay, thank you for that. And actually, we did have a lot of feeds about cats. And so I want to go through a few more of your questions, but then we do want to talk about cats today, I think.
I think you all have made a couple recommendations on puppies growing too quickly. What is the recommendation of what we should be feeding, or what percentage, what should we be looking for, having the owners strive to with regards to large breed puppy growth?
I'm going to just quote an older study where the puppies that ate 3/4 of the other puppies by 6 months of age. And this was a Great Dane study, but by 6 months of age, they weighed roughly half. These were male Great Danes, so it was worst case scenario, but at 6 months, they weighed half of the dogs that ate as much as they wanted. So basically not as much as they want. And by decreasing a small amount, you will slow down their growth quite a bit, even though they will not be starved and they should have the same size ultimately. That's all I know in nutrition, so I wanted to put it in.
Weren't part of those data too that at a certain endpoint after they were adults, that it was found that they're roughly, in other words, the dogs are genetically programmed to get to a certain size and shape. And so we're not going to interfere with them getting to their ultimate size and shape unless they starve. Okay, I just want to make sure. Unless they starve. But the point being that it's up to us to reframe this for our clients and help them understand that these dogs just should and can grow more slowly in a more controlled way. And think about the rib coverage test. Because if they're Kate Moss, they're growing too slowly. And if they're your big fat palm, they're growing a little too quickly.
Yes, please do.
I'll get on the soapbox here a little bit on this large breed thing where everybody sits back and says, well, we can't let them, get too big too quick. And I think there's probably some panosteitis out there that could be due to high growth rates, and we could probably sit here and debate that for years, I think, maybe. Anyway, so, and HOD and things like that, but what you have to realize is we still have breeders out there that are telling everybody to go ahead and feed an adult food. Because it's the same thing, because when you profile, it's the same. It's 24% protein, 12% fat, just feed an adult food. And there's evidence out there that a lot of those adult foods have way too much calcium in them, and so stick with your large breed formulas because they are being appropriately balanced with calcium, phosphorus, and the calories that they need.
2 thumbs up for that.
That was great. Thank you very much. And just a reminder to our questioners and our answers, our responders, please hold the microphone as close as you can to your mouth so the folks at the back can hear. And we have a question right here.
So a lot of attention was paid today to the snowballing effect of osteoarthritis with both the malalignment and inflammation and the role of obesity in inflammation. My question is, when in the process of that snowballing do we start implementing which anti-inflammatories and which surgical therapies to correct malalignment and to correct the inflammation? It's hard to guess sometimes how far to go. So what advice do you guys have on when we start what?
Back to you in a moment. I think you'll run the gamut of all of us with an answer to that. And some of it is opinion, but honestly, by the time arthritic change has set in, often your surgical interventions may be too late, maybe not, but they might be. So at the first sign of pain, and this even goes back to a previous question, when it's coming to recommendations for owners of what to do, I guess as a veterinarian, my first job, I think, is to get the animal out of pain. I don't think anybody or thing should live in pain. So I start considering that, working it into a multimodal approach so that they're losing weight, dealing with their pain, getting up, becoming more mobile. But if there is any question that I'm not sure what to do with this case, I find someone who does. And so the question becomes, when is it time to refer to a specialist? Because if arthroscopy is not something you're doing in your practice, let's send them somewhere where someone is and they can at least get a consultation. I spend a lot of time talking. I hate Thursdays and Tuesdays because I call them my jabberjaw days. I just talk from 7:30 in the morning until whenever we get done at night. And a lot of times that will yield surgery, but sometimes it doesn't, but it yields a better quality of life for the patients that I'm seeing. So don't be afraid to refer something if you've got an animal that's not doing okay and there's a definitive cause, whether you can find it or not, someone surely can.
I'll say 2 things. One, there are very few surgeries that really are protective in the long term or have been shown to be protective. There's not that many studies also. Maybe the juvenile pubic symphysiodesis might fit in that category. We're finishing a couple long-term studies that we'll publish, or maybe we can protect hips in the long term. The other part of the question was about NSAIDs. I'm always looking at NSAIDs as a means to achieve something. And at every stage of OA, we talked about maybe puppies. I want the puppy to maybe grow and socialize well or be trained well. So intermittent NSAIDs are all you need most often, and that can be helpful. later on, the weekend warrior dog, maybe we just need him to get back to normal. So again, a short-term NSAID might help. In the later stages, in dogs that are exercise intolerant, and it would be really good to have NSAIDs for a longer period of time until they're no longer exercise intolerant. We work on their weight, we work on their exercise, and they no longer need their NSAIDs. At the last stage of the disease, when they can barely walk, usually NSAIDs are going to be needed for a longer period of time, and you still have the same goals, try to win them off, but it might be a harder task.
Thank you very much for those responses. And as you know, we're live streaming this around the world as well, and y'all has been monitoring the global feed. So we do have a question from elsewhere in the world, and then we'll come back to your question here.
So this question has come from Holland, and thank you, team, for sending it through. It's from Holland, and it's for Dr. Downing. So you're popular everywhere in the world, as you can see here. And it is, what should we do with a colleague who says nothing is wrong with this cat, that is painful, but because we can't see anything on the radiograph? So the cat is obviously painful, but the colleague does not want to treat. So how can you change that compliance?
So we help that client run screaming from the building, because clearly they need to see a veterinarian who's more savvy about cats. And we can look to the data that came out of Texas A&M and understand that 90% of cats who are 10 years of age and older do have radiographic evidence of osteoarthritis in at least one joint in the body. And so we don't see osteoarthritis on the x-ray fails to be an excuse for not treating an animal that's clinically painful, because we know that the radiographic changes don't happen until we are at a very end stage. And unless someone has actually, well, let me use the example from human medicine. If you have back pain and your physician suspects that you may have osteoarthritis in your facet joints in your spine, you are actually going to go in the magnet and have an MRI. Because by the time radiographic changes in your facet joints show up, you are nearly fused. And that's really a context that we need to understand, that we can't see radiographic changes of osteoarthritis until that osteoarthritis has been present a very long time. So really, it's kind of a twofold response. That cat needs a different veterinarian, and we do need to respond. Sorry. Susan Little's going, yay, sister. And number two, we need to treat. We need to drive our clinical treatment bus, because there are plenty of pathologies out there that we can't see with our eyeballs, but we can see clinically. And those pets don't deserve to be suffering in silence or not silence without our intervention.
Holland says thank you and happy King's Day, because it's the King's birthday today.
Okay, and we have the microphone somewhere in the middle of the room. Thank you.
Do I have to? Okay. Oh. My turn? Okay. I have two questions, actually. One question is, what is the best age for skeletal development to spay and neuter? Because I've heard different things on that. And then the second question, was one I put through the feed earlier, which was about patella and patella surgery. If it's not inflammatory, when do you decide to do that? I've heard early if it's 3 or 4. So.
Spay and neuter question. Spay and neuter question. Who would like to talk about that? And skeletal development.
Now, here's the thing. That's going to be a moving target as more data becomes available. Because, again, looking at Dr. Hart's data, in the golden retriever, we reduce the risk of musculoskeletal disorders and cancers of all types by delaying the gonadectomy until the animal is sexually mature and skeletally mature. Now, Dr. Hart will be the first to say, I don't know what the optimum date is. I just know that they need to be mature. And yet in other breeds, it's not making a difference based on the retrospective work that he's done. So this is a moving target. We don't have one right answer, and I'm going to defer to my surgical colleagues because maybe they know something that hasn't yet appeared in the literature.
I definitely don't know of anything that hasn't appeared in the literature yet, and the literature is split right now. And so I think, again, it's just client education. What's ideal for the animal and what's ideal for the client. You're going to certainly reduce behavior problems. Problems is probably not the right word, but you're going to reduce sexual behaviors that some people don't want about male dogs if you neuter them earlier. However, if you have an increase in joint pathology because you neutered them earlier, what's the trade-off? What's the right time? And I don't think that anybody knows. And so there is not, to my knowledge, a real, aside from the female dog, of waiting more than 2 heats and the incidence of mammary carcinoma, there's not a real con to waiting that isn't more behavioral in nature. So I think you're dealing with health problems and behavior problems, and those 2 things are very difficult to figure out what is, quote, more important. Still, the most common reason for destruction of animals is behavior-related issues. So what is your ultimate goal? And there's not, I don't think, one single answer for that.
Just a little general practitioner doing the surgeries, because I think there's a lot of specialists who probably aren't doing spays and neuters very often. It is a sticky question, and what you find is if you are having the conversation with the owner to do it later, don't discount it so much. When you're doing a spay on a 100-pound fully grown Mastiff at a year old, it shouldn't be what you charge that 4-month-old 30-pound dog. It's a bigger surgery.
And I'll be the first to tell you I hate a spay, so yeah.
Thank you. And your second question was about patellar surgery. Our surgeons. Do we need to, do you still have the micro, do they need the, Dr.
I don't, so there are a full range of dogs with patellar problems, and some of them are very healthy, they use their leg well, and some of them are really messed up, they have, they shift weight, they have bilateral lameness, they might lose range of motion. Sometimes the patella is so luxated that the knee does not extend well, the quad becomes a bit of a flexor, there's a lot of tibial torsion. If it's, so you look at the range of the disease, and dogs that you see early clearly need surgery very, very quickly. Any dog that is going to go into some limb disuse situation, a foot that's not hitting the ground, from a rehab perspective, is going to be very difficult to manage. So these dogs need to be aligned. It's very hard to regain extension, for example, if you've lost. I've seen dogs that have lose 50 degrees of extension in their stifle because of a patellar luxation. So those should never wait. The ones that are healthy, that have the little skipping that's once in a while, then it's less obvious that they need a surgery, even though maybe patellar luxation might predispose to cruciate problems. There are, a bit of information about that. It's fairly hypothetical, and I wouldn't really worry about it in patients that are intermittently lame. They can just exercise regularly, and we'll go from there. I wouldn't rush those.
Thank you very much. We have a microphone right here.
Hi, I have a question about pain scoring. Do you have a reference like we have for body condition scoring for recording pain scores in the record? For example, if you had a patient that had orthopedic pain in the knee and that same patient had an otitis and had a lot of pain in that ear, would you list those body parts separately, and how would you score them?
So at the moment, probably the easiest to use pain scoring, validated pain scoring system is the one that came out of Colorado State University. Was really designed specifically for acute pain, and ideally in the perioperative period. They are now also are in the process of releasing a chronic pain scoring system as well. But here's my guidance to my colleagues who are like me in the trenches in a general practice. It's less important what your system is in terms of how you would compare your pain scoring to the practice down the street. It's much more important that the pain scoring that happens in your practice is consistent patient to patient. And while inter-practice, inter-observer variability is extremely high, in a small group of individuals with practice and training, that consistency can be quite high patient to patient in your practice. So unfortunately, what often happens to us as veterinarians is that in lack of a one right answer, we are immobilized to do nothing. And in fact, it would be more appropriate for your practice to say, okay, we're going to start scoring pain, and we're going to score 0 to 10. We score 0 to 10 in our practice. 0 is no pain, 10 is passing a kidney stone. I used to say 10 was birthing a baby until I realized that I was committing reverse sexism, because so many of my patients or clients will, like the male ones, will never know what that's like. And we began evaluating, like, what, in our practice, what does a 3 look like? In our practice, what does an 8 look like? I can tell you that when they scream, fall to the ground, and try and bite me, they're a 9. And I really appreciate the part of your question when you ask, do we discriminate about where the pain is occurring? Like, would we, if they have back pain and otitis externa, would we score the pain in those body parts differently? And the answer is yes, because the pain is different in those areas. They may have a screaming otitis, and that you would score an 8 or a 9. You can barely get to their head. And at the same time, they may have low back pain in the iliopsoas that you might score a 2 or a 3. So it is important to look at the whole patient. And the pain scoring that we do, the pain assessment that I do in the exam room, is a pain screening assessment. And it takes no more than 1 to 1.5 minutes to accomplish in the scope of my physical exam. It's a screening. And then if I find an area with which I'm suspicious, then I go back after I've done the rest of my physical, and I pay more attention to that spot. Does that help? Yeah. Okay.
Thank you very much. And, you know, we love to focus on the clinical. And remember at the beginning, repeatedly through the morning, our speakers encouraged us to diagnose as early as we can and talked about prevention as well. So we had a really great feed this afternoon that came in when we were talking more about the art of veterinary medicine that I'd like to give to our panel. And that is, how can my healthcare team engage my clients in discussions about preventive care without the client feeling like we're just trying to sell them something all the time? What advice do you have? Maybe.
So I'm not necessarily an expert in this, but when it comes to social media, I can say that case studies are the best. So just kind of showing some case examples of pets that are on preventive care plans or just on preventive care protocols, just kind of going over some case studies with your clients and really showcasing that tends to work really well, I find, with practices.
I also think we probably do much of this already in our examination rooms. There's the nice picture of the heart with heartworms or the tick poster up there. And I think it goes back to very similar to social media. It's not a hard sell, it's not a hard push, but even in our examination room when the receptionist or the client gets put in there by the nurse, for example, and they're having the initial conversations, I moved on. I'm actually very specific in when I ask them what medications they're on, because medications to them are quite different. I asked now in the exam room, are you on any prescription, over-the-counter, homeopathic? And I go down the list, because to them maybe an aspirin a day is not a medication because they get it over the counter, or their friend recommended it. It's not something that was prescribed. And then even with that, they often don't talk about the preventative measures they're on. So I say prescription, over-the-counter, homeopathic, and they say no, no, no. Are you on flea and tick or heart? Oh yeah, I'm on that. You prescribed it or somebody else did. And I think that really starts the conversation with the owners of what are you doing now? And that gives you the avenue to discuss, well, why are you not on preventative care medication? You know, this is the time of the year, or this is what it can do to help. So I think it goes back into getting a good history, and ultimately it goes back to communication. It's not really we start with the hard push and saying, are you on this? Ask them, what are they on? What are you using right now? And if you're not using it, here are some advantages of why we do recommend it this time of the year or year-round, for whatever that medication may be.
Thank you very much, and I think we have a microphone here.
Yes, as a leader and a female in a practice, and you're working with other females and some males that also like to gossip and do that kind of stuff too. How do you harbor an environment of positive empowerment for everyone, where everyone feels like they are contributing, not gossiping, not picking each other apart? How, as a leader, do you help have that environment occur? And when you get into the situation where there is a negative situation that is affecting the entire clinic, how do you handle that? Because I feel like some women really want to, myself, want to talk it out and really make this big deal of it and try to figure out a solution. My boss, on the other hand, likes to ignore it. And I want to know, how do you come to a medium place with that and make it figured out?
I just wanted to start, and I don't know there's going to be an easy answer to this because veterinary hospitals tend to be very high school-like at times. Close-knit, you work together all the time, you're constantly around each other, and it can be a difficult environment. And I think it starts from the top. You have to have leadership, which I don't want to say doesn't tolerate that, but to some degree won't tolerate that, and has somebody strong in place, which is leading by example more than anything else. And when something happens that is not favorable, and we in our hospital, it happens every once in a while. There are numerous examples. 3 or 4 nurses or doctors gossiping near an owner which is grieving over her very sick pet. And I think you have to stop it right then and there and say, just pull them aside and say, this is not the right time. There's something going on over there. Or maybe we shouldn't be doing that. Or if there are nurses that maybe are picking on another nurse, which happens with hierarchy in a hospital, it's important right then to pull them aside and say, maybe this isn't the right situation or the right time to do that. And then you have to follow up. It's not something which just at that moment you kind of just brush it away and say, don't do that. Then at a time maybe clearer heads prevail, you bring them into the office and you have a discussion with them, well, what was going on there, how can we fix that in the future, and sort of get them to understand why you were concerned. I'm sure they didn't mean to be laughing at something near a grieving owner. They didn't appreciate it, but the walls are thin sometimes in hospitals, even in 2 examination rooms. The laughing room and the euthanasia room are just next to each other, and they don't understand or maybe not realize it at the moment, and maybe as cooler heads prevail and as you talk it through, they'll understand in the future that's not the best thing to do. So I think number 1, it's important to have leadership in place which sets a good example, and number 2, to have leaders yourself as well as other parts of your staff on the floor which are able to or feel comfortable pulling another member aside and saying, just this isn't the right time.
Well, and I think it does from the leadership. One thing that can be easier often, I think, is powering the practice manager, having a practice manager and giving them the power to be the one that steps in instead of just one boss veterinarian type of a situation. And then the triangulation is really what you get into. It's so much easier to complain to you about him than it is to go to him and tell him the problem I have. And once I get it off my chest, I'm done. I can move on. Yet I haven't really dealt with what's been bugging me all along. So the most powerful part is the listener. If you're the listener to the gossipy thing or the complainy thing about that other person, is to be reflective and put it back on them. Say, can I help you share that with them? Or can I help you go to the practice manager so we can work this out? It's not a good dynamic. And then the other part is a very powerful, you can do this at team meetings or staff meetings. There's an article, I don't know if we can still find it out there, that was really powerful to me because I'm notorious for coming out of the exam room and like, oh, I can't believe this client was so dumb, they didn't know this, they've been giving that. And it really is a lack, it's not they're dumb, they are ignorant of what they should be doing, and it's like us with our cars. And there was a great veterinary story where she goes out to get in her car and it's like barely starting, making a horrible noise. Her mechanic comes through the rain after hours, helps her get it started. She hadn't changed her oil in like 3 years. There was all these things, maintenance she had not done. And she sat there, and he's so nice, got the car going, was very polite to her about getting in for the oil change, whatever it needed the next day. And she realized, I'm that owner. And he's being very kind, and I can just imagine the judging he's doing. So check your judging and think of it as a positive going forward way. So when you hear that dynamic in the back, try to shut it down and get them to put themselves in their client's shoes if they can. So one of the drills that we do in our practice, and when we get into that situation of the client that, my staff will be really frustrated because they don't know, or they're slow to adapt or slow to adopt. And so one of the drills we go through in our practice is just to remind ourselves that you can't know what you don't know. And so if, for instance, one of your team members is acting out, there may be something that we don't know is going on with them. So you can't know what you don't know. And it's up to us to figure that out, because once you know something, you can't not know it anymore. And so it may actually help us feed our compassion to think about the fact that whoever we're interacting with and who maybe is having a bad day, that there's something about that scenario that we may not know that may assist us.
Okay, thanks for all that wonderful commentary on that one, and we have the microphone there.
Do you think that the industry standard for most pet food companies for putting feeding recommendations for intact animals on the bag in a country that most animals are spayed or neutered is something that needs to be addressed by the industry as a whole, or AFCO, to maybe decrease the amount that owners are starting with feeding? Or do you think that they feed an amount determined independently of what the bag recommends?
Okay, I was going to ask our marketing team if they want to make a comment on that, but Dr. Tal has something to say, so.
Well, I'll just say that I have seen studies that would suggest less than 10% of owners pay any attention to what's written on the bag. So, while you can, say, well, that has an effect, it more likely owners that when asked were using cues like when the dog is full or when the bowl is empty to determine when they should stop feeding their animals. So while I agree with you there should be some standards, etc., I just wonder the impact that they may have.
One quick comment. I remember reading that dogs are at risk of gaining weight after neutering for 2 years after the procedure, but then the risk is no higher than whether they were sexually intact. And so there is a great review. We were talking about spay and neutering earlier. There's a review, a JAVMA review, that is open access that you can download and read that was talking about that.
Thank you very much. And we're almost at the end of our time for Q&A, and I want to go back to some of your feeds because I can't leave the Q&A session without addressing a couple that were quite common. One is very specific, and it's for Dr. Tal. And then the other, I do want to touch on cats before we go, because we had lots of questions about cats. So Dr. Tal, you talked about the evidence that exists for the value of nutritional management in clinical cases. And this question asks about any evidence, what commentary do you have on evidence that we have for the value of nutritional management of osteoarthritis prior to obvious clinical signs?
I wish that I could tell you that there are long-term studies that document starting therapeutic nutrition like JD-Canine early is beneficial. Those studies don't yet exist. We do know from the studies that have been talked about today that maintaining a healthy weight throughout life certainly has a benefit. But I would suggest that based on pathophysiologic rationale, grade 4 evidence, but at this point it's all that we have, that because we know studies show abnormal gaits in overweight animals, that there are elevated biomarkers for joint damage in overweight animals, in some 60, 70, 80% of dogs have joint instability depending on their breeds, and that repetitive forces on those unstable joints are going to cause damage to the chondrocytes. That anytime you're talking about instituting a disease-modifying intervention, the earlier you start modifying that disease process, the better the long-term outcome could be. So if I were in practice today, every dog that I suspected was going to have abnormal joint pathology, so most every Labrador, Newfie, Saint Bernard, pick your breed, whichever one, anyone, any cruciate, any dog with any kind of unstable joint, I would have them on JD-Canine or therapeutic food long before I knew that there was actually clinical disease, because that's when you're going to have the best long-term outcome. And that's the important part of convincing owners that we're doing this to delay the need for anything other type of intervention. So just an opinion, grade 4 evidence, but and I'd be happy for other input.
I would just second that.
Okay, great comment. All right, so we're at the end of our time together, but there were a lot of questions about cats, and literally the most common feed that came in about cats, some of our speakers were speaking about weight loss, some were speaking specifically about osteoarthritis, so I'm going to turn it over to our panel with the most common feed about cats, and the question was, what about cats? So think about your talks, if you would, and what commentary you might like to, depending on what your topic was, what you would like to say about the answer to the question from our audience, what about cats? Dr. Downing.
Predictably enough, first of all, get those clients with cats in the habit of coming to the practice for monthly weigh-ins. Make sure that you are attuning your practice to be cat-friendly, so you can help that cat be happy when they come to see you. The scale doesn't lie, and so cats that look like ticks today have the opportunity to look like cats tomorrow. And so, but it's all about, okay, maybe not tomorrow, maybe in 3 or 4 months. But anyway, the point being that get those clients in the mindset. We already know that cats are underserved. We already know that cats don't spend nearly enough time in our practices. If we can teach those cats when they're kittens to come and see us monthly or every 2 months for a weigh-in and nothing bad happens, first of all, we reframe the experience for the cat owner, because it's really the cat owner that's intimidated about bringing the cat to the practice. But we also reframe the experience for the cat itself, because we help that cat have a good experience, a positive experience. They don't get poked with a pointed stick when they come and see us. They don't get waterboarded like Guantanamo with an up-the-nose vaccine. They just have a great experience. And by doing that when they're babies, we'll have a much better time managing them when they're older, and we may actually prevent obesity in the first place.
Yeah, we didn't talk much about cats when we talk about obesity and inflammation, and the reality is we don't have a lot of information about cats, but that's partly because we just don't have the biomarkers available to really study it very well. But the reality is if you want to choose one model that really kind of recapitulates the human pre-diabetic syndrome, it is the cat. I mean, the cats are the ones that probably have all the raging inflammation and things like that going on, and I think that's really sort of the, once again, the underserved population as far as biomarkers and as far as how to deal with them. And I will tell you one thing, from a feeding perspective, stop using cups with cats. Quarter cups aren't quarter cups. I have my kids measure out their different quarter of cups, and there's about a 10 to 15 gram difference between my generous daughter and my chintzy son. And get a gram scale. Feed based on grams. Everybody in Europe does it for cats, and they're like, why do you guys have all these problems? I'm like, because we still use cups.
All right.
Thank you very much.
Having said that, tomorrow it will all be about cats, just to make you feel good. Tomorrow is all about cats. So, Susan.
Oh, I just want to... I just want to once again thank our speakers for their very hard work today. And to thank you for your kind attention through the day. We were blessed by having a plethora of excellent speakers to maintain our attention, but we know it was a long day, and we appreciate your attention and your caring about the subject.